Hello, everyone. Welcome to the COVID-19 virtual Q&A broadcast, our first as UHN Foundation. As many of you know, Toronto General and Western Hospital Foundation amalgamated with the Toronto Rehab Foundation on April 1st. So we welcome our repeat and new viewers to the UHN Foundation community. We hope you're staying safe and taking care of each other during these challenging times of the third wave of the pandemic. I'm Christian Cote, host of the UHN podcast, Behind the Breakthrough, and we're glad you could join us. We're also very grateful to our group of donors throughout the past year who've been so generous. So a big thank you on behalf of the foundation and all of us at UHN. This episode, we're focusing on how to get the vaccine safety and efficacy, and the third wave. Plus, we'll be taking your questions later in the program. With us today, we're so pleased to be joined by one of our live stream regulars, Dr. Alon Vaisman. He's an infection control physician at UHN. Welcome, Dr. Vaisman.
Thank you again for having me.
Let's get right to it. Let's start with our community here at UHN. Let's begin with trying to bring some clarity to what's been, I think, a confusing rollout in terms of the vaccine the last week or two. Let's start with the vaccine registration process here with who's eligible to register and who can get the shot in terms of how do we do it? How do we get online to do it?
Yeah, there's a lot of questions, definitely, because there's a whole variety of groups of people who can be eligible to receive the vaccine. The first group, as we all know, was the people who were working in frontline staff in the hospital, as well as those working in the community associated with UHN who are frontline healthcare workers. And of course, anyone living in a residential facility or long-term care facility. As for our patients, as everyone knows, the age restriction has come down over the last few weeks. We started off at 80. Now we're down to 60 for the entire province. As for other groups, there are other specific groups that the province and the city has tried to target in order to get vaccinated first. Some of these groups which can register immediately include Indigenous individuals, people who are provided home care at UHN, people who are faith leaders, and some priority neighborhoods in Toronto. So even if you're all the way down to 18 and above, if you're living in a priority neighborhood within Toronto, you can register to get vaccinated. The other important group that's also can register to get vaccinated is the people in the high risk or highest risk groups, who are those who have some kind of comorbidity which puts them at higher risk for getting COVID. So those individuals include those with some rheumatologic disorders, people who are receiving chemotherapy for cancer, people who have an organ transplant. If you're not certain whether you qualify or whether you're within these groups, there are many resources you can go to. You can go to the UHN webpage and look for the UHN vaccine registry area, or you can go to the City of Toronto if you live in Toronto and go to their vaccine area. Or if you live outside Toronto, you can go to any one of the public health units. And of course, you can always go to the Ontario website. These websites have been designed for you to enter your information and for you to figure out whether you can pre-register or register depending on who you are.
That's great. Okay, so for UHN, just for everybody out there, it's uhn.ca. At the top of the page, there is a vaccine registry link that you can click on, and that should have all the details that Dr. Vaisman just went through. Let's turn to the general community. Because of all of the sources you just mentioned, there still seems to be confusion about, where do you go to register? And keep in mind, registering doesn't mean you've got an appointment. You register to be called for an appointment. But there is the Toronto registry, there's the Ontario provincial registry, there's these mobile units. Pharmacies are taking registrations, and I understand even pharmacies are taking walk-ins. How can we make sense of all this?
Yeah, it's absolutely a good thing that we have many options, that everyone in Ontario and in the City of Toronto can go to all these various sources to find a vaccine. So you could choose any one of them. You can start with the City of Toronto if you live here, and they'll give you a menu of options in terms of hospitals that you can start with. You can start with the UHN as well. If you are interested in getting the AstraZeneca, for example, you can call a local pharmacy to get that. The other two vaccines, Pfizer and Moderna, are the ones that will be predominantly given in either of these resources. If you are living in a high-risk area that's identified through special postal codes, and to check that, go on the City of Toronto website, or if you live in York Region or Peel Region, you could go to their website as well, and they'll identify whether you live in that postal code. So I recommend to most people to start either with a provincial website or start with your public health unit that you live in. The public health unit will be the one with having the most resources, the most up-to-date information for you. And also they've done it in such a way that they can organize the listings based on what's closest to where you live. So if you don't want to go very far to get your vaccine, given that you're going to have to get two, you can decide based on that. So all of these are great options for you, and all of those that you mentioned are available on the public health websites.
Okay, and if you don't mind, Dr. Vaisman, just a brief review of where are we at with age groups?
So across the entire province, we're essentially at 60 or above. However, those who are 50 and above can get vaccinated in numerous sites that have been individually picked out in certain high-risk areas. And even beyond that, there's people who are 18 and above who can pre-register, and even more in some of these more well-defined high-risk areas based on postal code. So the general answer is 60, but still there's a lot of people who are 50 and above. That's actually being offered in several regions in Ontario already. So we're already down to, practically speaking, 50 and above for the most of the province. So we're coming down very quickly now as we go through the vaccination process.
Okay, let's move into the specific vaccine of AstraZeneca, because there's been some safety issues raised in the last few weeks in terms of the real world data coming back with cases of people in rare cases coming back with cases of blood clots. Talk to us about what Canada is saying about what age group is safe to get this vaccine.
So the initial concern from the AstraZeneca vaccine was based on the development of clots in a handful of individuals who received the vaccine in Europe. And we're talking about a very, very small number of people, somewhere in the range of 1 in 100,000 to 1 in a million, somewhere in that range. And as a result, they found that these the clots were developing through a very unique mechanism in the body that is similar to a drug-induced mechanism found with another medication. This development of a clot has been particularly noticed in young individuals, often young women. And as a result, the statement went out by NACI, the National Immunization Council, not to provide this vaccine to especially young people. Currently in Canada or in Ontario, we don't actually offer the vaccine to that group even before the statement came out. So it actually hasn't changed the approach right now. It may make a difference if down the road we need that vaccine, but we don't have supply of other vaccines. But as of this moment, though, that hasn't really changed our approach. And the basic understanding is that in that lower age group, the approach is whether your risk of dying from COVID is similar or higher to the risk associated with the vaccine. And that's the calculation that has been made and estimated by the National Immunization Council.
So in Canada, we're saying it's safe for people 55 years and older. But a number of European countries have, such as Italy and Germany, have said it's safe for people 60 and over. So help me understand, because I'm sure this would be a cause for some concern for people here in Canada. Why are these European countries being more restrictive, say, in who should get it than we are in Canada?
Yeah, there's a few things that go into the decision making for any country to make a decision around how they're going to vaccinate the population. Firstly is how the COVID pandemic is trending in their nation. If you need to have a more broad vaccination program, you might lower the age cutoff if you need to vaccinate people much more quicker. Both these ages are not really based on any specific cutoff in scientific literature. They're just kind of based on what they estimate to be the balance between the risk of developing clot and the risk of acquiring COVID and dying as a result. So what we do know is that the younger you are, the more likely, based on a handful of cases, to develop this complication. So they estimated based on their country's parameters, the way the COVID vaccine has been handled, the way the cases have come up there, that 60 would be a safe cutoff for them, whereas in Canada, a lower age cutoff. Practically speaking, there isn't much difference. The actual likelihood of that complication occurring in either of those age groups is extremely low, and hence why the recommendation in Canada.
With the first case actually of a blood clot side effect being identified here in Canada and Quebec, I understand today, do you foresee this perhaps causing some sort of pause on the AstraZeneca vaccine at all here in Canada?
In order for the regulators to make a pause on the vaccine, generally speaking, they'll have to see a pattern of clots occurring after the vaccination. So if you think about the average individual who's 60 years old, what is the likelihood that they'll develop a clot, say 60 days of any year? If that number is lower than the number we see after getting AstraZeneca here in Canada, then that would concern us. That would mean that there is an association. So there's always a baseline risk of everyone developing a clot. However, if that's the same as if you're getting the AstraZeneca, it doesn't increase the concern. The other thing to keep in mind is that of course, we should consider if there's a baseline, this risk is higher than baseline, but we should also be comparing it to what's the risk if you get COVID. If you acquire COVID and you're 55 or older, your risk of having a bad outcome, either being hospitalized, going to the ICU, developing a clot, or dying, is extremely high. It is in magnitudes higher than the risk associated with the vaccine. And that's what I think we need to keep in mind when we're considering these vaccine side effects.
Okay, so let's move into your sort of immunity, if you want to call it that, after you've had your first dose of the vaccine. When do we hit optimum sort of protection from the virus after the first dose of the vaccine?
So there's now some preliminary data based on the trials and based on real world experience of countries who have who spaced out their vaccinations, where we believe that there is likely around the day 10 or day 14, your vaccinations, your immune response to the vaccine is quite good. It's not quite as good as if you had received the second dose, but it is long lasting as far as we know. And this is based on studies of approximately dosing about 2 months. And now we're going to get more data in Canada, particularly what it's going to look like in 3 and 4 months. But at the moment, the reason that we're spacing out the vaccines is in order to get the vaccines out to as many people as possible. So we do think that a single dose does provide a high degree of protection. And even the partial protection that it provides likely also reduces the probability of dying as a result of the virus. So any amount of vaccine that you're able to take is going to be protective.
And in terms of that second dose, the recommended gap of 4 months, I understand that's the recommended sort of high end in terms of the gap. Is there any new information or any real world data yet that has indicated whether that needs to be moved up, or do you think it will be moved up?
So we know that in a subgroup of people, those who are severely immune compromised, those receiving an organ transplant, have generally not as good response with the first dose. And hence, for that group, there is going to be prioritization of getting the doses put together more likely than the rest of the population. But the practicality in Canada, the real world situation we have in Canada is that we don't have vaccine production in-house. So we need to import it from other nations. And that is the primary reason why we need to space out our doses between instead of doing 21 or 28 days, out to 4 months. The thing is with these vaccination dosing schedules, nothing is set in stone. The reason 21 days was set out in the first place back in the fall was based on the trial manufacturers trying to get the vaccine out as fast as possible. There wasn't anything magical about 21 or 28. So it was a balance between trying to get a high degree of immunity and trying to get the vaccine out quickly. So ideally, we do get vaccine fast and we get people immunized quickly, but we have to recognize that there's a balance here when we have a limited number of vaccines available to us.
So I'm just curious, if we see a kick in terms of vaccine supply over the next several weeks, people who organize these sorts of things are obviously mindful of, if they have more supply, they'll lower the gap between our first and second dose.
Exactly. And that was actually part of the news or the updated statement from the National Immunization Council just this past week, that they stand by the decision of recommending the 4-month spacing, but they recognize that once supply is improved, that there is going to be certain priority groups where they would want the vaccine spacing to be shortened so that certain groups will be vaccinated quicker. As I mentioned, there's going to be immunocompromised people in that group, but probably also healthcare workers who have only received 1 dose. That's another group that are probably going to be prioritized to shorten the gap quickly, and maybe those who are very elderly, for example, above the age of 80.
Okay, so as more and more people in Canada and in Ontario are getting the first dose, what's the public health guidance in terms of our behavior once you're up to sort of that optimal 10 to 14 day period and you're up to your optimal protection from the virus?
The general recommendation for the public is no different than if you had not been vaccinated. And the reason is, to some extent, there is the partial immunity, although it is quite good, but also there is an importance of trying to model good behavior amongst the population, trying to, with the equitable distribution of vaccines, trying to make sure that everyone is behaving the same regardless how many vaccines they receive. Some uncertainty around whether to what degree you can transmit the virus as well with just the 1 dose or even with 2 doses. This is very different from what's recommended in the United States, where the 2 people who've received 2 doses, a lot of alleviation of restriction has been recommended for that group. In Canada, we have yet to make any kind of changes on that front, partly because it still hasn't been a significant number of the population, We are quite behind in terms of getting everyone 2 doses of the vaccine. We're so, about not even 1 in 5 yet in Canada. So hence there hasn't been any changes.
Okay, so and I guess another incentive for maintaining the same sort of behaviors before you got your first dose or second dose is the fact that with all these variants emerging and now dominating the case counts each day, what's the latest, or what do you know about the efficacy of the vaccines we're getting in terms of the variants?
So the most predominant variant, which is now, close to 90% across Ontario and Canada, the B117 variant, which originated in the UK, we know that the 2 most common vaccines we are distributing in Canada, the Pfizer and the Moderna, are both effective against this variant. So hence the importance of getting vaccinated as soon as possible. As for the other variants that have originated elsewhere in the world, or sometimes they are referred to as E484 mutants, those are the certainty around the protection against them is not as high, although most people would agree that there is at least partial immunity against them. There is constantly new data that is flowing from real world and in vitro data about whether or to what degree it's protective. A lot of in vitro data saying that it is protective. In other words, experiments done in the lab. Then there's some real world data saying that it's not as good. But at this point, our management is unchanged. In terms of how the country is vaccinating, we still want to get as many people vaccinated as possible to protect us even against these other variants, which are not as frequent, which may be around 10 to 15%. And even if there's only partial immunity against them, that's still very, very important.
And I'm hoping you can clear up sort of a nagging news item that keeps coming up every now and again, over the last several weeks, is that there is vaccines sitting in fridges or freezers, not in arms, and that doses are being held back. What's your take on this, or what's the rationale for this if this is indeed the case?
Yeah, when those freezer comments are made, it's to some degree it's a political statement that is either made by the province or the federal governments, because the federal government is responsible for supply and the provinces are responsible for distribution. So to some degree, quoting these numbers or saying they're down or up is used as kind of like a poke one way or the other. But there's certainly something to be said about improving the distribution. If you take Ontario, for example, about ramping up as fast as we can. And absolutely, the idea that anything should be sitting around in freezers would be absurd. To some degree, of course, it requires the population to sign up for vaccines. We know that in the age group of 70 and above, when it was available in the city of Toronto, there were still lots of spots available. So there's lots of work being done on numerous fronts for various communities in the city to try to ramp up vaccination. So there's so many angles to this, people wanting to vaccinate, also going out there. As you mentioned, there are mobile units, there are convention center, there's all sorts of things being increased. The more we can do, the better. All hours of the day, ideally. This is a public health emergency. We need to be using all our resources to get it done.
Agreed. You mentioned, let's turn to the third wave. You mentioned the mutation protein E484K. I understand that's common to all the variants, and it is in large part driving the variants becoming the dominant COVID case count. Talk to us about this mutation and the severity of it.
So just to take a step back, the variants that arrived in Canada probably around January or a little bit before that, they all have this mutation called N501Y, and that's a mutation that's found in the UK variant just as well as the other ones, the Brazilian or the South African. The Brazilian is otherwise known as P1, and the South African is 1.135. That 501 mutation is what we think confers a higher level of transmission and is also more dangerous. People are more likely to die or have complications as a result. The E4084K mutation is also found in some other variants, namely the P1 and the 135. We think, based on some data from those countries, that mutation, on top of the other one, makes it more likely for you to be reinfected with that strain compared to the other ones. So if you had a different strain in the past, you may be more risk of acquiring these new strains as a result of that mutation. Currently, those 484 mutants make up maybe 10 or 15% of the strains. So it is very concerning. But the ones who carry that mutation, again, are also more likely to transmit, and they're also more likely to cause you to have bad complications as a result of the other mutation I mentioned earlier.
And you mentioned the British variant or the UK variant is most dominant in Ontario, up to around 90% of the daily case count. It's had also an effect on the shift in the profile of patients being admitted, right? Like what's different from the first two waves in terms of this third wave, in terms of the patients we're admitting?
Yep. So if you look at the average age of people in the ICU right now, it has definitely dropped. In UHN, for example, it's dropped by at least 10 years when you look at wave 3 compared to wave 2 or wave 1. Part of that, of course, is the fact that patients or the individuals living in long-term care facilities have been, for the most part, vaccinated, although not all of them. But it's also because the transmission has been more prevalent, has been harder to manage. And so even young people who were previously not acquiring the virus, even doing their day-to-day activity, even doing the right things, with even a few transmission events, this has led to a lot of transmission across the province. So there is probably an association between the fact that we have more variants now and the fact that there's younger people affected. Also, because it's more severe, we are seeing more of these young people getting into hospital, unfortunately. And so that's how we've seen that the age of the people being admitted drop recently.
And we've seen in Ontario, our ICUs are being stretched to capacity. You see this week, scheduled surgeries have now been canceled to make room for COVID patients. We have the outdoor hospital at Sunnybrook. Sick Kids is now got an ICU ward for adults. What does the modeling tell us over the next few weeks?
Yeah, when we started off in the middle of March or around there, end of March, the number of patients in the ICU was around 400, and it's currently just above 600. The initial modeling at that point had suggested that this may reach 800, and that would be to some degree optimistic based on the assumption that there is a strong effect from the lockdown that was issued last week. So whenever you have a lockdown, you expect approximately 10 days, 14 days, or 20 days or so for there to be an effect and perhaps there to be a peak if it is effective. So 800 was earlier estimated to be the peak based on that. So that's what we're looking at, or maybe even higher, maybe close to 900 or 1,000. These numbers, they seem very abstract to people. It's hard to wrap your head around how many ICU beds we have in the province, but it's enough to say that this is extremely high. This has reached the boiling point in many of the, especially in Toronto, many of the ICUs here. They're stretched to capacity. They are going to make accommodations to try to put patients in ICU beds to make sure that they are staffed. There is a lot that goes into looking after a patient in the ICU, of course. There's nursing, there's physicians, there's RTs, OTs, all sorts of people that's required. And that's just being stretched further and further as we go into the next 2 weeks.
So what are you looking for then, Dr. Vaisman, over the next 2 to 4 week period, now that we are into a lockdown? What's going to tell you that we've hopefully made some progress or turned the wave around?
Just like in wave 1, the name of the game is to protect the hospitals. If we don't protect the hospitals, then even patients who do not have COVID will not be able to get care. As you mentioned, elective surgeries have been canceled. So the ripple effect is massive across the entire system. If you can protect the hospitals, if you can keep capacity at a level where they can continue functioning, then the COVID pandemic has less significance, comparatively less significance. If COVID is just a disease that people get as an outpatient, they never need to get to hospital, then it's not as important. So this is the key metric that's going to be examined over the next few weeks, is what's going on in the hospitals. Firstly, the ICU beds, which is the most scarce, and secondly, the general ward beds. Once we see a turn in those numbers, we know we're making the difference.
And as part of trying to make that difference, I this week, I understand after spring break ends, school will resume, but online only across the province for the next several weeks. It's tough on students, parents, and teachers. What's your take on this move?
It's always very unfortunate when schools have to be closed, but I think most people would agree that schools should be the last thing that we close in society in these lockdowns. We should try to close as much of the other economic activity before schools. And the reason is that schools not only provide a direct benefit to children, but also provide a direct benefit to the caregivers and the family members who are looking after them. Being able to, it has such a massive effect on everyone who has kids in terms of just workplaces across the province. So ideally, this would be the last thing to close and the first thing to open. the only way to safely reopen the schools is if these numbers are trending in the right direction, which it looks like, anticipating the next few weeks, doesn't look like it will be at that point when March break is over. So it certainly makes sense. We certainly need to see a downward trend before it makes sense to open up the schools, because of that two-way transmission between the schools and the community, and other way around too.
I know I don't want to pin you down in terms of an actual date, but given that we're in this lockdown, schools are back to remote learning only. What is your sense in terms of when does wave 3 start to descend?
If we look at the effect of the previous lockdowns in Ontario and other parts of the world, then it's, as I mentioned earlier, be about a 2 to 3 week point where you'd start to see the effect of that, and then the turning of the curve going down. So if we assume that that's the case this time, then it looks like the last week of April or first week of May.
And in your work, you're on the front lines. You're there when outbreaks happen, and you have to declare, as part of your department, the Infection Prevention and Control Department at UHN, to protect staff and patients. You declare outbreaks. What are you hearing from people on the front lines? How are they doing?
It's been extremely stressful for people to have to go through this so many times. There is, of course, the benefit this time that many of our frontline staff are vaccinated, but that doesn't change the stress that they're experiencing. What's different, as we discussed earlier, is that the patients now are younger, and to some degree that adds another level of anxiety, another level of tragedy to the pandemic, on top of the tragedy that has already been experienced by the frontline staff. We're now into month 13 or 14 of this pandemic, so the stress that has been taken on these frontline staff is enormous. And the message we're trying to encourage for people, for myself, other frontline, other healthcare workers, is that at least this time we can bridge this wave to vaccination. If we can get enough vaccines in people's arms and in patients and staff, hopefully this will be the last time we experience it.
Yes, since the vaccines became a reality, we keep hearing about how we've got to get to herd immunity. What's your sense? To declare the pandemic over, we have to get to it. Does this rationale still hold for you?
Absolutely, and there is real world data now. We can actually look at a country, Israel, and look at what they did and see the numbers. So they're at, in terms of 2-dose vaccination, they're around 60%. And many of their economic activity has been opened up. Many public events have been opened up. And so that, and keeping in mind that the population of 80 or over was around 90% of the 2-dose vaccine. So that is a reasonable goal. Of course, the goal is to go even further, and Israel is going further, and we aim to go further. But that is a real concrete number that we can look at. Of course, things will be different in Canada. There's different population, different age groups, different susceptibility groups. So it may not be 60% here. The point is that there is a real light at the end of the tunnel here, which is different from how we experienced things over the last 10 months or so before this.
Okay, well, we'll end this portion of the live stream because we've had so many questions today, and we always try to get to as many as possible, and we always feel we've given short shrift. So let's get to your questions out there. Dr. Vaisman, Ontario has chosen to vaccinate up to 4 months apart with very few exceptions. How much protection and for how long do seniors and the immune compromised population have with only 1 dose? Will there be enough immunity left after 4 months for the second vaccine to be effective?
Yeah, that's a great question. Unfortunately, we don't know the answer for some populations. The population that we know best of for this 1 dose is the transplant population, where if you look at the antibody levels produced from 1 dose compared to a non-transplant patient, we know that they're not quite as good. And hence the advocacy from, for example, the transplant group here at UHN to bring their doses close so don't have to wait for 4 months. As for other groups of people, the elderly, presumably there is less of an effect on somebody who is very old, but we don't know for a fact how that affects the overall transmission. So we hope that, again, as we mentioned earlier, that as vaccine supply improves, these will be the groups that will get vaccinated quicker, sooner.
Next question from Cher. We're told it's safer outside, but how safe? I can smell someone smoking 8 feet away. The smoke wafts over. I imagine COVID expelled into the air from infected individuals can waft on over too. People jog by without masks. I immediately think I should cross the street to get out of the airstream.
Yeah, there's been a lot of focus now on outdoor transmission. We have some data, for example, a study from Ireland looking at the overall rate of transmission, and people who have presumed transmission in the outdoors is very low. They account for a very small percentage of the total COVID cases in a country. So we think that outdoor transmission is quite rare. If you are in close contact with someone in the outdoors, you should definitely wear a mask. If you are transiently walking by somebody or they are running by you, it would be very unlikely for them to transmit COVID to you. So for the most part, you don't need to wear a mask. However, there are always going to be exceptions on a busy street or in a busy park or on a playground, for example. It certainly makes sense to wear a mask there. But otherwise, you should generally try to keep your distance. Don't go out if you're sick, of course. You should quarantine. Those are some things that you could do to try to reduce your risk. But I think going outside is one of the most important ways we can encourage people to avoid high-risk behavior indoors. I think we need to really focus strongly on making outdoor activities safe and as a way to avoid doing the other high-risk stuff.
Next question. After a Pfizer vaccine, what is the level of protection for someone on immunosuppressant medication?
So we spoke about this just a second ago about the transplant population is not quite as good, and that's based on antibody levels. How it translates in the real world with real world numbers is unclear. I should also add for the general population, we estimate or has been estimated that protection could be anywhere between 50 and 90% in terms of preventing disease at all. And I should note that that's very different than what we talk about when we talk about mortality or hospitalization. We don't have as exact numbers on how well one dose prevents hospitalization or mortality, but certainly there is a significant protection there as well. So it's very important when you hear these numbers about protection to understand whether we're talking about mild disease or severe disease. So that 50 to 90% we're talking about, that's just mild disease.
After being vaccinated, can you be an asymptomatic carrier of the virus and therefore transmit to others?
So after receiving 2 doses, it's certainly possible to get the COVID virus, absolutely. So when you look at Pfizer and Moderna, the trial numbers are somewhere between 90 and 95%. But that's not so important in terms of the motivation to get vaccinated. The number we should be focusing on is 0. 0 is the number of people in the trials who died of COVID, and 0 is the number of people who got hospitalized with COVID after getting 2 doses of these vaccines. And that's really, really important. If you're an asymptomatic carrier or have mild illness, you're still probably able to transmit the virus after 2 doses. However, it's likely that the viral load that you carry is low, because we know that viral load somewhat correlates with the disease severity. So the likelihood of you transmitting is comparatively less had you not been vaccinated because you have milder illness.
Are both doses of vaccine equal in quantity, or does the second dose differ by being more potent? More side effects seemingly result after the second.
So the actual dose that you're given is the same, whether it's the first or second dose. In some individuals, there may be a higher chance of some mild reactions occurring after the second dose because of some immune priming. So with some people who have exposures to some allergens that give them allergic reactions, a second exposure can be more severe than the first. However, overall, the risk of having an allergic reaction from these vaccines is extremely rare and does not frequently happen in the general population.
This is a good question, actually. I hadn't thought of this one. Once it's determined when we will require a booster shot, I'm guessing the annual, sort of like the annual flu shot, does one need to take the same type of vaccine as their original shot? I.e., if you originally had AstraZeneca, can your booster be Pfizer, Moderna, or another, which is being given at that time, i.e. Johnson & Johnson?
So first of all, if you get the first shot of any vaccine, you can't mix and match and get some other vaccine. You have to get the second shot of the same one. If you've gotten 2 doses, or let's say the vast majority of the population in Canada gets 2 doses, what will we give people after that is a huge question. I suspect that will be based on the best available science at that point about what is simply the best vaccine. That may be based on the population, elderly, immunocompromised, the young, as we do for a flu vaccine, for example. Over the years, there's been multiple flu vaccines, and there's certain flu vaccines that have been preferable for elderly. versus the rest of the population because of their ability to protect people. So I imagine that when we get to that point, we'll have more data on which groups should get which vaccine. But there wouldn't be any specific reason why if you got 2 doses of one vaccine, you couldn't get 2 doses of a different vaccine. It's just about what works best for you. And hopefully we'll have a better sense of that. This is really down the line, though. We're talking about near the end of 2021, if necessary at all.
Right. Question from John. It seems that even with full vaccination, we still need to take the same precautions, masking, distancing, washing hands, etc. At what point in time will these precautions not be required, and any estimate of the time frame?
So as was asked by the previous question about, can you still be an asymptomatic transmitter of the virus if you get 2 doses? That is part of the reason why the recommendations in Canada haven't changed regarding masking and everything and distancing. So you still can transmit. When we get to a certain point in Canada where our herd immunity is very high, then a lot of people have been vaccinated, whether that's 50%, 60%, 70%, that may be a point where these recommendations will be altered, because the overall likelihood of you even picking up the virus will be very low. And so the risk of you not wearing a mask or not distancing after having 2 vaccine doses is low. So to answer that question is basically whenever we get to the very high proportion. In America, they kind of went that direction very early. But in Canada, I suspect it's going to take quite a while before we get there, a very high degree of herd immunity.
Next question. Of the new COVID cases showing up currently, what percentage of those have had the first dose of the vaccine? In other words, how safe are we with 1 dose of vaccine versus no vaccine?
Right. And this goes back to my earlier comment of there being a wide range of approximation of how protective the first dose is. If you look just purely at the trial data, somewhere between 80 and 90%. In real world data, depending on which study you look at and which country, it can range. The low end the lowest would be something like 50%, and the high end will be somewhere around 90%. So it certainly depends on which vaccine and which setting you're talking about. But that would be a rough estimate of picking up any form of COVID.
Wiping down groceries was a common practice in the first wave, but most seem to have dropped it. Now that we have variances, I'm guessing that means variants, which are more contagious, should we be renewing the practice?
So in general, COVID likely does not transmit very well on surfaces. And there's certainly a level that you need a level of protection that you need to use when you're doing these kinds of things, like washing your hands. But beyond that, wiping down groceries is not really recommended or not really necessary. So before you eat or prepare food, it makes sense to wash your hands. That's probably all you need to do.
Is it safe for 4 people who have just had 1 dose to socialize indoors, have a meal, watch a game on TV?
So even still, as we mentioned earlier, even if you've had 1 dose, you have the ability, even more so than if you've had 2 doses, to pick up the virus and get sick. The likelihood of you picking up the virus is certainly lower. The likelihood of you having severe illness is lower, but it's not 0. Hence, there hasn't been any changes here in Canada or even the US about recommendations around people who've had 1 dose. We would still recommend that people who have 1 dose of the vaccine follow the same guidelines and not congregate, not have a meal with one another, who are not in each other's homes, not sit around and use these practices. It's still very important to continue that, even if you've had 1 dose.
Well, logically following from this, if you were someone who is not carrying it, but you go to this dinner party, you could get it there. And even though you don't get symptoms, if you go home and you have, say, young children, you could pass it on to them.
Exactly.
Would it be possible to have last call lines at clinics for no-show appointments and end-of-day remaining vaccines? If so, why don't we have them?
I think that's a great idea. I think that's a very smart way of using the vaccine, making sure that we optimize the usage and get it out as fast as possible. I think various hospitals have taken some approach related to this. I don't know the specifics for each hospital, but some may be taking this approach. But in general, they are following the guidelines that the Ontario Ministry has set out in terms of who can get vaccinated when. So I'm not sure if some of them have all used the approach of having a wait list for people who are eligible but have an appointment down the line to bring them up sooner. It certainly makes sense to me to get as many people vaccinated as possible using that method.
Yeah, it's a great idea. I had my first vaccine shot on March 26th. I took Tylenol and Aleve to relieve my arthritis pain before my appointment. Today, I read that OTC killers should not be taken before the vaccine as they may diminish the creation of antibodies. Is that correct?
Yeah, the recommendation from the federal government or the federal body, the PHAC and NACI, they have some of them have actually made statements around this that you don't need to routinely take any painkiller or anti-fever medication, for example, when you take the vaccine. If after you get the vaccine, you have these side effects, it's certainly safe for you to take it, but you don't need to routinely take it. And if you have taken it for some other reason, it's likely not going to be not going to have a major impact on you. So I would say to everyone, don't take anything when you get a vaccine, unless you have to for some other reason. And only if you have side effects, go ahead and take a medication that helps.
How frequently should one change one's mask? What about washing disposable 3-layer masks in order to reuse? Proper washing techniques of cloth masks?
At this point, I think most people would agree that your disposable masks are probably a good for one day, and maybe even less if you've contaminated it or if it's become soiled in some way. As for the disposables, again, it makes sense the non-disposable makes sense to wash them probably once a day. If you've used it infrequently throughout the day, you might get away with longer usage. But the pressure washing technique for a lot of cloth masks, it's very similar, and usually they come with instructions as well if you purchased one from the store, similar to other clothes. And being very, very careful to look at the material, follow the instructions, and also look for tears in the mask. If the mask is torn or permanently contaminated, just toss it out and get a new cloth mask. Yeah, generally speaking, using it for one day makes sense.
I have some dental issues without severe pain, but sense that things are brewing. Should one be going to the dentist at this time if it is not for emergency care?
It's a good question. I think it's a balance for every individual to ask for themselves. Some dental issues, of course, are going to be more pressing. They're going to affect your quality of life. It makes sense to delay whatever you can at this stage, given that the pandemic is really out of control right now. The number of cases are immense. But I can't speak for that individual to say whether the pain or whatever it is they're experiencing related to teeth shouldn't be looked at. There are lots of safety measures that have been installed in dentist office to protect patients, to protect staff. So it's not to say that you're at high risk when you go to those places. It's just to say that whatever can be delayed now should be. So, that most healthcare things that we need to look after shouldn't be delayed because they usually have a consequence down the road. So I would advise people who have dental problems to speak to their dentist about that and get advice.
From Ali, she says, when people are double vaccinated and arrive in Canada from an international destination, they must take a PCR test within 72 hours of their arrival to Canada. Upon arrival, they are given an additional COVID test. If both these tests prove negative, why must they quarantine for 14 days?
Yeah, this goes back to the approach that Canada so far has taken of not changing the guidelines for those who have had vaccination, as has been done in the US for travelers or others. So we just simply haven't done that yet in Canada. Again, partly that's because there is a small risk of transmission. And secondly, it's also because the overall number of people who have been vaccinated is low. So the likelihood you pick it up is still reasonably high. So that's really why those guidelines haven't yet been changed in Canada.
We still seem to know little about COVID-19. Why do some people get it and others do not? Why do some people get COVID-19 more severely and some die than others? What work is being done on biomarkers, blood tests, etc., to test how likely one is to get COVID-19, and if so, how severe it will be?
Yeah, the work around biomarkers for getting COVID-19 is not as well understood as the biomarkers that are activated when you have COVID-19. And certainly there's a lot of work going into research for individuals who are coming into hospital, trying to predict once you have COVID-19, what are the biomarkers that predict a more severe outcome? And a lot of those have to do with your inflammatory response, your immune system's response to getting the virus. As for your risk of getting COVID-19, that's probably not as well understood when it comes to testing things in the blood. We know that there are, of course, similar risk factors for other infections. Any form of immune compromise, being elderly, having comorbidities, those are all things that will put you at higher risk of getting COVID. Then there's individualized risk factors like what kind of exposure did you have face to face? Was the person symptomatic? Were you symptomatic? There's all sorts of those variables. which we use in infection control and in OC health to understand the risk of acquiring infection. But going down to the biomarkers, that area has not really been well developed yet in that specific question.
Why is Health Canada not mandating or very strongly recommending N95, KN95, or equivalent masks instead of cloth masks now that the supply is there? It seems logical that this will provide more protection. Do we really need more data for this kind of decision?
Yeah, I understand the concerns that the public has and frontline staff have about whether we should be wearing N95s. For the general public, the N95 is not a practical solution because the N95 needs to be fitted. So these are specific to one's face. There are certain models, and you need to go get tested and figure out which model is appropriate for you. So it's not really a practical recommendation for the general public. And generally speaking, in most settings, the added benefit of an N95 is likely minimal when it comes to the activity of the general population. As for frontline staff, there are absolutely certain settings where N95 is recommended, and those are where the risk is higher. For example, when aerosols are more likely to be generated as a result of a procedure. But as far as routine care that's provided from frontline staff, the recommendations have not changed across Canada because the science has so far not changed with regards to infection control data. And hence across the provinces, across Canada, based on the current best available data, there hasn't been a change yet.
Next question from Mark. I'm a new dad with a 10-day-old baby. Congratulations, Mark. There have been little information about transmission, vaccine efficacy, and risk while breastfeeding. Can you share details on what the research says in these areas and what the current guidance is for vaccination and safety protocols for moms and newborns?
So very early on in the vaccination plan, pregnant women were not recommended to receive vaccine in Canada. However, that was very quickly reversed. And in the United States, in the UK, and other nations, vaccination in pregnancy was recommended. So far, tens of thousands of women, pregnant women, have presumably been vaccinated without any reported side effects, including breastfeeding women. And an interesting formal study was done recently in about 150 or so pregnant women that did not show any adverse outcomes, pregnant and breastfeeding women, that did not show any adverse outcomes in the mom or the baby when they were born. And there has been some case reports showing that the antibodies that mom gets from the vaccine have been passed on to the baby.
Wow.
The significance of that is unclear yet, whether the baby is immune or to what degree they're immune or for how long. But so far, the best available data has not shown any adverse outcomes specifically in pregnant women or their babies or in breastfeeding women. So those are not contraindications to get vaccinated. If you're pregnant or breastfeeding, it's important to have a conversation with your doctor, with your obstetrician or family doctor, and discuss the risks and benefits of vaccination. But at this point, given where the pandemic is at and the risks of the VOCs, the variants, most people would recommend vaccinating in that group.
I live in a condo in a red zone and use the elevator to get down to the parking level, about 30-second ride. Assuming I get into the elevator by myself right after a sick person left it, will I get infected by aerosol during my ride?
So aerosols can certainly hang in the air, and there's at least a theoretical risk that they can infect people after an individual has long left or is no longer in the room. We particularly recognize that in healthcare settings when we do procedures on patients that are aerosol generating. When a person who is sick is in an elevator, they likely do produce a small amount of aerosols that have the capacity to infect. After that person has left, based on what we know, the likelihood of them infecting another person is generally going to be very low. So wearing an appropriate mask is likely going to be able to protect you against that small risk. So this is what the recommendation remains, that you wear masks, of course, whenever you're around people, wherever you're indoors, but the likelihood of transmission even still is very low.
I know the answer to this next question, but I'll let you take it. If you have had one shot 3 weeks ago of AstraZeneca at a pharmacy, now a second pharmacy that I had registered at from before is telling me to call and get an appointment, is it ethical to take that as a second shot?
No, so we should follow the recommendations of when the AstraZeneca should be given. So in the trials, it was 12 weeks apart, and that was the original dosing. So you really shouldn't be getting it faster than that, based on the trial data, based on the first recommendation. And that, of course, the other part of it is spacing out to 4 months is the other guidance from Ontario. So it wouldn't be ethical for you to get, nor would it really be consistent with the best available data for you to get vaccinated with a second dose immediately after your first dose of AstraZeneca.
Well, plus there's a record when you take the first dose. If you show up 3 weeks later, that record has to be disclosed, and people will, of course, catch on that you're trying to get a second dose, and that's not going to work, is it?
There is definitely a record. I just don't know how the records communicate with each other and how each pharmacy communicates, but presumably that happens, and presumably we don't over-vaccinate people.
Next question. 16 to 30-year-olds are having a hard time following the social distancing rules. I don't know if that's completely true, and many are not. Presumably, these groups are contributing to the spread in a meaningful way, passing it to their 50, 60, 70-year-old parents. Why don't we vaccinate them now? That's a good question.
So it's probably true that, that age group has the capacity to transmit as well as anyone else. There's probably little doubt around that, and that they're practically adults, 17, 18-year-olds. But the bottom line is that vaccines are still a scarce commodity. If we were in a country where we had tons of vaccine supply, US, Israel, other places, yeah, we should vaccinate them too ASAP. But the bottom line is that we don't. We have only so much vaccine, and we want to protect those who would be directly affected and those who would most likely have a bad outcome. As we started with the most elderly people, ones in long-term care facilities, and working our way down. That's still the most sensible way to vaccinate people, is who's most likely to get it and who's most likely to have a bad outcome. But yeah, I absolutely agree. 16 to 30-year-olds should be vaccinated. Once we have enough supply, I encourage everyone in that age group to get vaccinated.
Once the mRNA vaccine enters our body, does it keep on reproducing the spike protein even though the body doesn't need it anymore in the future?
That's an excellent question. It gets to the heart of how this vaccine works in the first place. It's such a genius design. This mRNA is a small genetic code from the virus. It's not the whole genetic sequence, just a small one for this spike protein. mRNA is a code that's found in every human. Anything that's alive on Earth has mRNA in it. So bacteria, bananas, elephants, they all have mRNA. That's just a code that tells your protein what to produce. When the mRNA enters your body uses that mRNA to code a protein on the top of its cells. And the immune system, the B cells, for example, they come across this spike protein and they produce an antibody. Then your B cells now have an antigen, have an antibody to produce. If you're exposed to COVID, you have the antibodies to fight it off. That mRNA lasts a very short time in your body. It's degraded very quickly, perhaps within a few hours. So after a while, that's gone. You're no longer taking in that mRNA. You're no longer producing that spike protein. So even after, long after the vaccine has gone out of your body, what you still have is the antibodies against it, not the mRNA that's been degraded. Your body eats it up and uses it for other, its purposes. So it does its job very quickly.
What do you recommend for someone who received the first AstraZeneca shot and does not want the second?
I would say that your best bet of getting complete or the highest level of protection is getting the second dose of AstraZeneca. The likelihood that you will die is reduced if you get the second dose, as far as we know, the likelihood to get hospitalized. So it's not to say that one dose isn't sufficient, but you want to do your best to protect yourself and the ones around you. So I would ask them why they didn't want to get the second dose, and I would ask them if there's because of reaction or something else. But I would encourage everyone to get a second dose because it improves your likelihood of protecting yourself. Just going back to that previous question, that they specifically asked whether the spike protein is continuously produced. It's likely that after the mRNA is gone, there's nothing left to code to give you the spike protein, so that is gone as well. You're not going to be producing spike protein for forever, or for even a few days. Once the code is gone, the protein production is gone.
Right. Referring to the possibility of serious blood clots that might be associated with the AstraZeneca vaccine, what symptoms should a person receiving that vaccine be watching for?
So this is a very unique pathogenesis of a clot is associated with a exposure to a medication, or in this case, a vaccine. The clot symptoms are those, it's kind of non-specific, but very important ones to watch out for would be headache, changes in your vision, sometimes fever, rapid heart rate, chest pain, trouble breathing. Other clots may form elsewhere in your body, like in the leg, so swelling of the leg, pain in the leg. But the really critical and the most concerning forms of clot related to this would be those in the brain. So headache, difficulty with your thinking or confusion, pain, vision problems, those would all be the very concerning symptoms to watch out for.
And if just, I've looked for this because my partner has taken AstraZeneca. If you go to the Ontario Science Table, it has a whole sheet, one pager of what to look for in terms of those symptoms. Very helpful. From Debbie, what measures should the government have taken to better control this spread of the variants of concern?
It's a very challenging aspect of the pandemic because these variants arise independently in various places around the world. And in order to completely protect your country from them, only thing you can do is to close your borders completely. Or if you don't close your borders, you need to have an excellent process in place to isolate everyone who comes into your borders. This includes the United States, where we have back and forth economic activity that is vital for the nation with truckers and other people working. So it's a huge challenge for Canada, different from other parts of the world that have a better control, like islands, for example. That's not to say you can't have better control. You might have been able to slow down things a lot more dramatically if you had more control over the borders. That would have been the best way to do it. It may be inevitable that the VOCs would have arrived in Canada through one way or another, but that would have been the way to do it to better control it, is through very tight restriction of travel and isolation of people who arrive here.
If you test COVID positive, having a confirmed contracted first strain, is it possible to still get one of the variants of concern? And can you only infect others with your specific COVID strain?
Yes, to answer the second part, you can only infect people with a strain that you have currently. And to answer the first part, if we look back to COVID reinfections with the first and second wave with the variants that were common in Canada, the likelihood of reinfection was quite low and didn't happen very frequently, and usually occurred after 3 to 6 months after the first infection. But now that mutation that we spoke about, the E484K mutation that's found in the South African and the Brazilian, or the P1 and the 135 variants, we think that those ones have the capacity to reinfect you quicker than if you had one of the usual strains. So that is the risk that we're dealing with now, that we're trying to understand. We don't quite know how high that risk is or how likely it is, but that is the risk and the concern that we're working with right now.
All right, next question. Our friend in Tennessee who had COVID was given only one of a 2-dose shot of the vaccine because they said he had antibodies in his body because he had had COVID. So is now fully covered with only 1 dose of Pfizer and doesn't need to come back for a second dose. So why are we not doing that here?
So if you had the Pfizer, you're not completely protected, as we talked about. You still do need to have the 2 doses of the vaccine in order to get the highest level of protection. So for this individual who's only had the 1 dose, they are not totally covered, or the most covered, as we would say. So this recommendation would still be for this person to get the second dose. In the United States, where supply is much better, they don't need to actually space their dosing. They've been giving the doses at a regular interval for the most part. So I would say that we should still be giving the second dose based on the best available data, that it gives you the highest level of protection.
And this, given our timing, probably will have to be our last question, Dr. Vaisman. Why don't we just call in the Army to assist with the rising ICU patients and exhausted staff, as well as the vaccine administration?
So there's certainly, so when you look at the resources required for ICU patients, taking the first part of that question, there are a whole variety of health professionals that are required to look after those people, those patients. So physicians, nurses, pharmacists, respiratory therapists, occupational therapists, porters, imaging techs. It's a long, long list of people. Whether or not we need to call the Army to get those kind of professionals, if they have those available, I think they would have to come to a very high degree of severity of crunch, of a human and health resources crunch. Still, the best people to look after them are the ones who work in your hospital, the ones who are familiar with the system. We would have to get to a point where we're really, really tight with being able to give people to look after them to get to that point. That would be a very, very drastic kind of situation. And I think a lot of hospitals are looking at ways to try to alleviate the pressures on their staff, try to alleviate the stresses. It's a very, very challenging thing for them to look at. As for vaccine administration, I think that's, if we don't have the people available, then certainly I don't see a downside to having staff from the Army come do it, because the amount of training required for vaccine administration is relatively low compared to ICU care. So certainly that sounds like a reasonable idea to me. I just don't know the practicalities of how it would be done, or whether we need those individuals to come in right now. But absolutely, I would encourage all that stuff, all the vaccine administration to be done as fast as we possibly can.
We're going to have to leave it there. We've come to the end of the hour, and I want to thank everyone who joined us out there. And I want to give a special shout out, thank you to our expert guest, Dr. Alon Vaisman, UHN infection control physician. Thank you so much for taking time out of your busy day to give us your insights and expertise, Dr. Vaisman.
Thank you for having me, and thank you for everyone for joining.
This live stream will be available on the UHN Foundation YouTube page, and we want to remind you about a new UHN Foundation initiative called Give a Shift. If you are moved by the amazing work that's going on at the UHN hospitals and the work of our healthcare workers at UHN, you can show them you give a shift. It's a first of its kind fundraising initiative to honor our healthcare heroes on the front lines and to raise funds for UHN. To learn more, go to it's Give a Shift. That's all one word, Give a Shift, all one word, .ca to find out more. And finally, donor support. It plays a critical role in helping Team UHN on the front lines as they care for and treat COVID patients. As well, donor dollars fuel the research that is ongoing every day in terms of coming up with new treatments and discoveries for this disease, as well as the other programs at UHN. So if you are able to and are moved to donate, we would ask you to consider making a donation by going to www.uhnfoundation, that's our new handle, uhnfoundation.ca/help. Thanks for tuning in. We'll be back next month with another episode. Keep an eye on your inbox. In the meantime, keep practicing physical distancing, mask up, and stay safe, everyone. Have a good evening.